The loop electrosurgical excision procedure is relatively simple but can be troublesome to teach. Previous studies have demonstrated the effectiveness of simulation training for increasing resident confidence and skill in performing LEEPs. Other authors have described simple, cost-effective simulation models using toilet paper rolls and yogurt cups. We have developed a similar but more durable model that can still be constructed for well under $10.
Our goal in this video is to describe the construction of our model and how we can use the model to teach the LEEP procedure. Our aim is to use this video in conjunction with a simulation skills lab to teach the procedure to residents, students, and practitioners.
The materials required for this model can be found at any local hardware store. In addition to the 2 pieces of PVC pipe, you will need a metal or plastic fender washer, a piece of particle board, super glue, and sausages or bratwurst to represent the cervix. To assemble our model, we first drilled a hole in the particle board just large enough to accommodate the threaded end of the PVC adapter piece. The hole should be within 2 inches of one end of the board so that the board does not interfere with speculum placement when the model is completely assembled. We inserted the adapter through the hole and screwed the T into place. Next, the fender washer was glued onto the back opening of the T-piece. A sausage can then be inserted through this opening and the fender washer will hold it in place. Enough of the sausage should protrude through the back of the model to wrap an electrosurgical grounding pad around the end. For the simulation lab, you will need the LEEP model including sausages, a 25 to 27 gauge epidural needle with 10 millimeter syringe which can be filled with water to represent local anesthetic, an electrosurgical generator and handpiece set at 55-55 blend fulgurate, a smoke evacuator, grounding pad, and loop electrodes in a variety of shapes and sizes. For our simulation lab, we use a colposcope with video capability. Tubing for the smoke evacuator can be passed through the open adapter end in the bottom of the model and secured with tape. Or, if an insulated speculum is used, it will contain a port for tubing. As you can see, the model clearly accommodates a speculum, but for the purposes of this video, we will omit the speculum to optimize visualization. The preferred generator settings for cutting with the loop electrodes are 55-55 blend fulgurate. When the roller ball is used, the coagulation settings should be switched to spray. In the clinical setting, additional equipment will be required, including a colposcope, insulated speculum, sidewall retractor, tenaculum, and forceps, 1% lidocaine with epinephrine, 5% acetic acid, Lugol solution, Moncels and silver nitrate sticks, and if necessary, a long needle driver with suture and suture scissors. Loop electrodes in a variety of shapes and sizes, including a square or rectangular electrode and a 3 to 5 millimeter ball electrode, should be available. Acetic acid is commonly used to delineate lesions. The vinegar solution dehydrates cells, causing dysplastic cells with abnormal chromatin density to reflect light and appear white. Lugol solution can be particularly helpful in defining the limits of the transformation zone and identifying abnormal non-staining areas not visualized with acetic acid alone. Due to their high glycogen content, normal mature squamous cells stain a deep brown color with the application of Lugols. Most LEEPs are performed in the office setting under local anesthesia. An effective cervical block can be achieved with 10 milliliters of 1% lidocaine with epinephrine. A long epidural needle should be used to inject the cervix at approximately the 4 and 8 o'clock positions. Care should be taken to avoid the large vessels which are located laterally at 3 and 9 o'clock. The needle should penetrate approximately 1 to 2 centimeters deep. Arcing the needle outward will make it less likely to exit the cervix laterally. Cervical blanching should be seen. Attempted withdrawal before injection is important to document extravascular position. A paracervical block is much more painful and unnecessary in most cases. The lesion and entire transformation zone should be excised in one pass whenever possible. It is important to select the appropriate loop electrode. Too small a loop results in incomplete resection of the lesion or requires multiple passes. Too large a loop can result in inadvertent amputation of the cervix. Before beginning, the surgeon should make several practice passes to determine the best route for the patient's particular lesion. Although the route should be individualized, the axis of the loop electrode should remain either parallel or perpendicular to the axis of the cervical canal, meaning side to side or vertically. Deviation from this axis can obscure the architecture of the cervix and produce an asymmetric specimen. Cautery should be activated while the loop is still several millimeters away from the cervix. The loop is then advanced at a right angle to the surface of the cervix, carried across the os to the opposite side, and removed at a right angle. The surgeon should strive for a depth of 5 to 8 millimeters and margins of 3 to 5 millimeters beyond the boundaries of the lesion. Excisional depths greater than 1 centimeter have been associated with increased risk of long-term complications such as cervical stenosis, cervical insufficiency, and preterm delivery. Although the surgeon should strive for clear margins, a positive margin on the excised specimen does not necessarily indicate a positive margin in situ, since several millimeters of the remaining cervical tissue may be obliterated by thermal spread. Notice the depth and lack of char in this specimen. When the vertical route is chosen, the surgeon should begin posteriorly and proceed anteriorly so that visualization is not impaired by bleeding. Sometimes the entire lesion cannot be excised in one pass. In this case, it is better to make multiple small passes than to use too large of an electrode. The first pass should include the cervical os. This allows better pathologic interpretation of the endocervical margin, which is where most invasive cancers arise. Afterwards, a smaller loop electrode can be used to excise the remaining areas of dysplasia. If the lesion extends into the cervical canal, a separate top hat pass can be utilized. This procedure uses a smaller, square or rectangular electrode to excise the more proximal endocervical canal. Again, the electrode should enter and exit the cervix at right angles. The excised tissue is removed with forceps, and pressure is quickly applied to the excision crater with a large swab until coagulation can be achieved with the ball electrode. Before using the roller ball, the generator coagulation settings should be switched to spray. The ball electrode should be used to coagulate any observed bleeding sites first, then the entire periphery of the excision crater. The presence of an IUD presents a special challenge. If the patient wishes to retain her IUD, care should be taken to avoid cutting the strings. This requires at least 2 passes. A large non-conducting swab can be used to elevate the IUD strings, allowing access to the posterior cervix. The strings are then displaced posteriorly in order to access the anterior cervix. Sometimes it is impossible to avoid IUD strings, and the patient should be thoroughly counseled about this possibility. IUD strings should not be spared at the expense of performing an adequate LEEP. The success of any LEEP procedure depends on the speed at which it is performed. The loop should glide through the cervix at a steady pace. Moving too fast will cause the loop to drag or bend, resulting in a more shallow excision than intended. In this specimen, you can easily identify the point at which the surgeon began to move too quickly. Moving too slowly, on the other hand, will char the specimen, making it more difficult to interpret, as well as the remaining cervix, resulting in greater thermal damage to adjacent normal tissue, more tissue necrosis, and increased postoperative scarring. As you can see, this specimen demonstrates excessive charring. The surgeon should take care to avoid interrupting current mid-pass, as it is usually impossible to reinitiate current while the wire is lodged within the cervical stroma. The loop electrode can then become trapped or overheat and break. Also, care should be taken to stop the current as soon as the wire is free of the cervix to avoid accidental vaginal sidewall injury. Moncel solution and silver nitrate sticks are usually sufficient to control bleeding associated with LEEPs. On rare occasions, a baseball stitch may be utilized. We hope this video has provided you with valuable information for teaching the loop electrosurgical excision procedure. We truly believe that practice makes perfect and simulation drills make a difference. We hope you will use our simple PVC model in your simulation labs to teach and practice LEEP techniques.